look forward to his presentation now.
Yeah, thank you. Thank you for this introduction, Ayub, and hope to see you in person soon. Before I start, let me thank Dr. Ms for inviting me, for having me here, and an excellent talk by our previous speaker. Both Dr. Nawaz and Dr. Yusuf have been very elegant in their talk. And let me share my slide. And well, I have been given a task to present on sphenoid bones and Sella Turcica. And mind you, this is the bone which is of very much interest nowadays amongst the young neurosurgeons, because the shift of focus initially when I was a trainee was much more on a temporal bone. In every meeting, they used to talk on temporal and the petrous bones. But nowadays, since the endoscopy has come into vogue, now everybody is talking about sphenoid bones and the way to approach the Sella Turcica as well as beyond it. I don't have anything significant to disclose in this presentation, except for this fact that I have taken most of my pictures from Rotten and other website, which I have acknowledged them by their putting their names on the slides. And this is a pure education and sharing experiences. So this particular discussion is about why are we doing this? Why are we studying the sphenoid bone and the Sella, and what is about the sphenoid bone? What are the anatomical parts and landmarks? The surgical importance about it and the surgical approaches in and around sphenoid. So when I was trying to prepare this slide, I just came across a website, a very interesting fact about this sphenoid bone, where one of the website blogger was putting it as a cause of lot of ailments, headaches, migraines, temporomandibular joint disorders, and likewise. But our interest as a neurosurgeon is to understand these bones, not only to understand the access to the surgical vision for cure, deconversion, biopsy, but also to protect the vital structures, restore the key anatomical barriers, and also to have the functional and aesthetic reconstructions. So from this viewpoint, from a neurosurgical viewpoint, I will be presenting this talk. So when we see the sphenoid bone, this is in the shape of a butterfly. And as in renderation by an artist, you can see this particular bone has a paired lesser wing, and then a paired greater wing on the side. Then it has a sphenoid body and a paired processes of medial and the lateral pterygoid. And it has a structure which looks like a butterfly from different perspectives, from anterior as well as the posterior view. And then in the superior and the inferior view, one can appreciate that the overall layout of the bone in such a manner that is much more placed vertically as compared to the horizontal placement. And the name sphenoid as such has derived from a Greek word called sphenodile, so which means basically wedge. So this is wedge between the anterior and the middle cranial fossa, and it actually gives a sort of a junction between the anterior middle fossas. Now it is completely hidden beneath, and it can be seen very small in quantity in the lateral view as well as through the orbit. And every young neurosurgeon who has his hands on the skull, once he starts making a craniotomy, has to go through this bone whenever he's going through the terrenal craniotomies. And just on again an anatomical rendition, one can see that how hidden it is to access it. And that's why it is supposed to be a very complicated bone to understand. But once we like to play with this bone in the 360-degree, we will be having a good idea about it. So this sphenoid bone makes one of the 5 bones, which is the component of the skull base and has a junction with the ethmoid in the front and the frontal on the sides. And then in the temporal bone on the side, and it continues in the calvaria in the form of a parietal bone, in license the parietal bone. And in the posterior aspect, in the posterior cranial fossa, in the midline, it is to the occiput, and in conjunction with the temporal squamous portion as well as the petrous, it forms the posterior portion of the middle fossa. Now, when we understand the attachment, which is very important, particularly from the endonasal perspective side, if we see the anterior aspect of the sphenoid bone, in the midline, it is attached to the sphenoid in the front and the vomer in the bottom, and then the palatine bone on the side as it comes anterior from the front. So this is the same picture which has been inverted upside down. Then when we see the maxilla coming in the front, the maxilla actually sits in front of the palatine as well as the vomer. And if you see this particular orbital roof, as Dr. Yusel was also elucidating to his presentation. This makes the component of the orbital cavity. And then this orbital cavity is actually made complete by the pallidum bone on the medial aspect, and then the orbital process of the frontal bone, which comes and sits on its top. So this sphenoid bone does not only makes the middle cranial fossa, but also makes a very important component of the orbit. And then when we go from the onto to the back, we see from the exocalvarial aspect or the exocranial aspect, where the bone is facing the soft tissues outside the brain component, it has a zygophyseal attachments to the occiput and the temporal bone on the sides. And then when we come inside, it has again these type of attachments, which is basically completing the middle cranial fossa and the posterior cranial fossa. Now we will be discussing each of these views in detail. So when we see the sphenoid bone bang anteriorly, it looks like a butterfly with a keel in the front, which is also the sphenoid keel, and it has two ostias on the side, which leads into the sphenoid air sinuses, which we usually open to reach the sella floor. And then on the side, between the lesser wing and the greater wing, is the superior orbital fissure. And this superior orbital fissure is separated from the foramen rotundum by a maxillary strut. And then when we come medially on the inferior aspect, this is the pterygoid canal, where the nerve of the pterygoid canal, also known as median nerve, comes through it. And this is a very important landmark when we are going a lateral approach in the transnasal sinuses. And then in the inferior aspect, we have the pterygoid processes, the medial and the lateral. And this is important from the front because most of the nerve, which the cranial nerve 2, 3, 4, as well as the V2, which comes out from the skull base, actually comes out through the various foramens, which is lying in the anterior aspect of the sphenoid bone. So this is the optic nerve, which comes out the optic foramen, and then the 3, 4, 6, as well as the branches of the V1 would be coming from the superior orbital fissure. Then the foramen rotundum, where the maxillary nerve will be coming out. So all these nerves comes out through the different foramina, which is lying in the anterior aspect. Now, when we come from the backward, from the when we look at the superior orbital fissure, the superior orbital fissure, which has an optic canal on its top and is separated by optic strut in between, is just covered by annulus of Zun, which is basically a muscular tendinous string, which has an optic nerve and ophthalmic artery inside it, and then the cranial nerve 3 and 6 together with the nasociliary nerve sitting inside it. Now, this is also known as orbital apex, and that's why, since we see some of the nerves are coming out or they are going out of these annulus ring, which is basically the lacrimal nerve and the frontal nerve and the cranial nerve 4 or the trochlear nerve. So whenever the patient is having an orbital apex syndrome, he will have ptosis, he will have proptosis, but he will not have the involvement of SO4 or superior oblique. Why? Because the cranial nerve 4 is sitting outside this annulus of Zim. So this is again artistic rendition of the same which we are talking about. And then the maxillary bone, or the orbital part of the maxillary bone, together with the greater sphenoid ring, which actually forms the inferior orbital fissure. So through which the inferior orbital nerve and the zygomatic nerves flows throughout. Now, when we see this particular sphenoid bone from the posterior aspect, this is very important from the vascular point of view, because the carotid artery, which comes out of the foramen lacerum, goes to the carotid cave. So the carotid caves are the bony impression, which is seen on the medial aspect of the body of the sphenoid. And the carotid cave actually allows the carotid artery to sit on it. And as the carotid artery goes through a 2 centimeter long horizontal segment, it turns upside up towards the anterior clonoid, and it comes out of the anterior clonoid medially. And this particular segment is known as cavernous sinus, which actually goes from the superior orbital fissure and ends up to the petrous apex. So this is very important from this aspect. And when we see the sphenoid bone from the top, one can visualize the Sella Turcica, which is basically bordered on the front by tuberculum celli, and then there is a depression which is known as hypophysis sella, and then there's a dorsum celli at the back, And the dorsum sella is actually bounded by posterior clinoid on the either ends. Now, anterior to the tuberculum sella is the prechiasmatic sulcus, where the chiasma sits on it, and in front of it is the limbus of the sphenoid, and then again in front of it is the jugum sphenoidal, also known as planum sphenoidale, which Dr. Yusel was also speaking in his presentation about. So this is from the endocranial aspect of the bone, which is actually facing the brain aspect. And then we can have a view of the foramen ovale and the foramen rotundum. So this, and then also the foramen spinosum. So foramen ovale gives a passage to the cranial nerve V3, that is the mandibular segment of the trigeminal nerve. And the foramen rotundum gives the way to the maxillary nerve. And the foramen spinosum is the outlet for the middle meningeal artery, which is important when we are doing a middle fossa approach. Now, when we see this bone from the inferior aspect, we see the basically the pterygoid plates, which is hanging up out, and then there is a pterygopalatine fossa, which actually goes laterally to communicate with the infratemporal fossas. So when this particular view from the right oblique is important for us to understand the optic strut. So if you remember, optic strut is the separation between the optic canal and the superior orbital fissure, and is also the posterior root of the anterior clinoid process, which I will be discussing in detail in the coming slides. Now, this is a superior oblique view of the same bone where you can appreciate the anterior clinoid process and its three processes. So the three process is one of the medial root, which makes the roof of the optic canal, then the optic strut, which is the posterior root, and then there is a process which attaches to it to the lesser wing. So these are the three processes of the anterior clinoid ring. Now, as we have discussed, the carotid, internal carotid ICA, internal carotid artery, comes out of the foramen lacerum and through the underneath the lingual ligament, petrolingual ligament. It comes into the clinoidal segment, and once it into the clinoidal segment, it goes through the lower dural ring into the clinoidal segment and comes out of the clinoidal segment outside the upper dural ring. So this is how the carotid flows, and there is an entity known as kissing carotid, which every endoscopic surgeon should be well aware of. So sometimes the carotid comes very near to each other, and when both of these carotids they are very near to each other, they becomes a dangerous point to hit on the transsphenoidal approaches because the carotid come into the way, and this particular kissing carotid can occur not only inside the sella but also in the clinoidal segment. Now, this is an artistic rendition. This is a cadaveric specimen to suggest how is the layout of the cerebrum as well as the ventricle in relation to this middle part of the sphenoid. So one can see the pituitary gland is sitting in this, the hypophysis sella, and just above it is the chiasma, and then there is a lamina terminalis, and then the third ventricle. So, and then the anterior circle of Venus is sitting on its top. So, any lesion which arises from the sella can actually go up and can cause a compression as well as involvement of these structures. So one should be aware of that. And similarly, in the coronal view, one can actually see that the temporal lobes, the medial temporal lobe is sitting very lateral to the sphenoid sinuses, and that's why the lesions can actually involve the temporal lobes there. Now, what is important for us to understand is that this sphenoid bone, since it is the layout of the sphenoid bone is much more vertical as compared to the horizontal. It is not creating a sort of a bowl for the brain content, but it is actually giving a passage for a lot of nerves and the vessels to flow across. So it gives a passages from cranial of 2 to a cranial of 6. Which actually passes very near to this sphenoid and over this sphenoid to the various anterior skull base and the middle skull base. And then there's a passage to the ICA, which is also very important to consider. So when we talk of ICA, we know that the cavernous ICA, which is actually coming out of the foramen lacerum and entering to the cavernous segment, it has only basically, it has been said to have 3 different branches: meningohyphacial trunk, then it can have an infralateral trunk, and can, in some cases, it can have a different artery. So the variations can occur. But when it comes out of the clinoidal segment, inside the clinoidal segment, it gives an ophthalmic artery, which comes underneath the optic nerve. And this particular segment is very important, the clinodal segment, because this is the only segment which has two dural sheets. So one should be aware of that when they're trying to dissect this particular area. Now, this is a cadaver which can show us the relationship of the anterior and the middle cranial fossa with the base. So once we take out the orbit, we can see that the sella, the sphenoid sinus, is basically is sitting in the mid of the middle cranial fossa. And this particular pterygopalatine fossa and the inferior temporal fossa are actually the lateral component, which is sitting below the middle cranial fossa. And then we can see that the foramen rotundum is coming out into the pterygopalatine fossa, and then the mesenteric nerve is coming out into the through the foramen of ovale into the infratemporal fossas. Now, this particular picture also suggests the same, and this is a very brief area for pterygopalatine fossa, which actually houses the pterygopalatine ganglion as well as the maxillary artery when it is coming out into the infratemporal fossa. Now, the most important structure, which from the vascular point of view, which most of the people have a difficulty to understand in relation to the sphenoid, is the cavernous sinus. So cavernous sinus is nothing but an interdural sheath. So these are two layers of sheath, which is actually making a sort of a keel of a boat, which has a top deck and a very narrow base. So this particular keel actually starts from the superior orbital fissure, as you can see here, and then it goes backward, and the posterior border is between the posterior clinoid and the petrous apex. And the base of the cavernous sinus is basically made by the junction of the median and the lateral dural fold, which is attaching itself underneath the internal carotid artery. Now, the roof is actually again formed by the dural fold over the petrous apex, over the anterior clinoid, and then there are three ligaments, three dural folds one should be aware of, which is important. One is the anterior petroclinoid ligament, which is basically the dural fold starting from the anterior clinoid till the petrous apex. Then the posterior border is made by the posterior petroclinoid fold, which is basically from the posterior clinoid process and the petrous apex, and the interclinoid fold, which is between the anterior clinoid and the posterior clinoid. So one can see in this figure also that the oculomotor nerve, together with the fourth nerve, passes through the roof of the cavernous sinus and goes through it. However, the sixth nerve and the V1 actually flows through the lateral wall of the cavernous sinus, and V2 and V3 are completely outside the cavernous sinus. So this particular investing fascia is very important for us to understand, because this gives a very good idea about how the cavernous sinus layout is all about. And one can also see in this figure that the IC is coming out of the outer dural ring in this particular flip. So cavernous sinus is basically a highway for all the veins from the anterior cranial fossa, from the posterior cranial fossa, as well as the middle cranial fossa to flow through it. And they also communicate with the other side through the anterior intercavernous sinus and the posterior intercavernous sinus, which is seen when we are coming from the endonasal route. And that's why this particular channel is very important for us to understand, because it has a lot of things into it. Now, when we see this particular thing from the top, this is how it looks like. So this is an optic nerve, and this is the IC, which is coming below it. This is the fascia, which is this is the dura, which is covering the anterior clinoid process, and this is the oculomotor nerve, which is entering into the oculomotor triangle. Now, when we see these dural attachments, then the most important dural attachment, which is also need to be understood, is a falciform ligament. So falciform ligament is nothing but which actually makes the roof of the optic canal, and this is very important when there is some tuberculum cella meningioma or some other tumors which is involving the optic, which is causing an optic compression. So we have to actually decompress the roof in these cases. So falciform ligaments needs to be cut. And then this is a triangle which is basically made by the optic nerve and the oculomotor, which is also known as clinodal triangle. So the clinodal triangle is one of the cavernous triangle, which is, once you open it, you can see this is the clinoid segment. clinoidal process, anterior clinoid process, and the ICA, which is basically the component of the clinoidal triangles. And the ring which I was mentioning about, the lower ring and the upper ring are basically the dural investments, which is actually coming up. In the case of the upper ring, it is coming from the superior surface of the anterior clinoid process and covering the ICA when it is coming out of the clinoidal segment. Whereas the lower ring is the dura, which is coming from the lower aspect of the anterior clinoid process and covering the lower part of the ICA. So the ICA takes a bend between these lower and the upper ring, and that forms the clinoidal segment of the ICA. Now, this particular triangle, which we have just mentioned about it is formed by the convergence of the two nerves, and that's why most of the triangle which is formed over the cavernous sinuses are due to the convergence of these nerves. So in this case, there's the clinoidal triangle, which we have just mentioned, and this is on the lateral view. So one can see the ICA as well as the anterior clinoid process after it has been truncated. Then the other triangle which is important for us to understand is the oculomotor triangle, which is another cavernous sinus triangle, which is made by the lateral fold of the anteropetroclinoidal fold. Then the posterior part is the posterior clinoidal petroclinoidal fold, and then the interdural fold actually makes the middle component. And the mid part of the oculomotor triangle is the entry of the oculomotor nerve into the cavernous sinus. So this is how it looks like in the lateral view. Then the third triangle, which is important for us to understand, is the supratrochlear triangle, which is formed by the lower aspect of the oculomotor nerve and then the superior portion of the trochlear nerve. And then the posterior portion is the dural side entry of the third nerve and the fourth nerve. So this is a very narrow triangle. And then the other triangle is the infratrochlear triangle, which is formed by the lower portion of the trochlear nerve and then the upper part of the V1, and then the posterior border is made by the dural entry side of these two nerves. So this particular triangle is also known as Parkinson triangle, and Parkinson once thought that this particular area can give a solution to the most of the cavernous fistula, because meningophypophyseal artery is believed to arise from this particular part of the ICA, which is hidden underneath. Then is the four triangles, which is important from the perspective of the middle fossa. But then these four triangles, the two triangles, the anterior medial and the anterior lateral, are the ones which are lying over the sphenoid bones. The other two, that is the posterior medial and the posterior lateral, are lying over the petrous bones. So they may not be the part of the sphenoid bone which is in the discussion right now. So when we talk of anteromedial triangle, which is made by the divergence of the V1 and the V2 nerve root, and it is made, and the anterior border is made by the junction of the line from the superior orbital fissure to the foramen rotundum. This gives an access to the maxillary sinus. And similarly, the anterolateral triangle, which is made by the lower aspect or the outer aspect of the V2 and the middle aspect of the V3, and then the line joining the foramen rotundum to the foramen ovale is the anterolateral triangle, which again gives access to the sphenoid sinus. Then just to mention here is the posterolateral triangle, also known as Glasscock triangle, which is made by the outer aspect of the V3. And then the posterior medial aspect is made by the GSPN, which is flowing underneath the V3 segment. So this actually makes the Glasgow triangle. And then the fourth triangle, to just complete the list, is the triangle which is made by the medially from the V3 and between the GSPN, and this gives an access to the posterior fossa. So the other important structure which we have been discussing in few of the slides before has been the anterior clinoid process. Now this is a very important process, because once we go through the neurocrinotomy or we do an FTUZ and we want to access the middle fossa base or the cavernous sinus, and this particular clinoid tip has to go off. And similarly, in the most of the cases of an ICA, clinodal segment aneurysm or ophthalmic segment aneurysm, we need to take off the clinod process. So when we take off the clinod process, there are two ways to open the clinod process. One is extradurally, the other one is intradurally. So the extradural process actually comes from the outside, and once you start drilling once you get to the superior orbital fissure, we just cut through the orbitomeningeal band, and then the anterior clinod tip is in front of it, and then we start drilling the anterior clinod tip in a form of a coring process. So we just eat up the mid portion of the bone, and then we just take the optic strut out, and then the whole anterior clinod process actually comes out like a tooth. So that actually gives us a method to open up the anterior clinod process. And the other method, as we have just mentioned in a few slides before, is to open up the falciform ligament and then come from medial to lateral. So this actually opens up the optic canal, as well as you can see the ICA is open after this anterior clinodectomy for any of the clipping of the clinodal segment aneurysms. Now, middle fossa approach, particularly the Hakuba's techniques, also uses this particular technique of going from the front to back and to dissect the cavernous sinus. I will not go into this operative detail because that's it's outside the purview of the stop. Now, coming to the endonasal route. So our previous speakers have already explained many things in detail. There are a few things I would like to highlight here is the sphenoid ostium, which is basically the key landmark to enter into the sphenoid. So as the speakers have already told that it is at the level of the at the level of the superior turbinate, but sometimes the anatomical variation may misguide you. So the most important landmark would be the choana. So the roof of the choana, it will be usually between 2 to 3 centimeters above. You will see the sphenoid ostium, and through the sphenoid ostium, one can enter into it. And the sphenoidal penetral artery is the most important artery to understand if you are raising the Hadad flap, because it cannot be sacrificed if in case we are trying to do that. So it's always better to make a Hadad flap in such a manner that you come below the sphenoid ostium, and that the superior limb of the flap comes above the ostium. So that's why the sphenopalatine artery can be preserved whenever we are trying to raise the Hadad flap. Now, when we go inside, we have already talked about MOCR and LOCR. So MOCR is nothing but the lateral most extent of the tuberculum sella. And this is the area where we'll be getting the internal carotid artery, where it takes a turn inside the clinoid. And the LOCR is nothing but the anterior clinoid process, which is actually we are looking from the outside from the sella. So anterior clinoid process is basically the LOCR, and now it has come into too much of prominence because of many of the para-optic approaches which has been defined, which place around the LOCR dissections. And so this is now coming into a lot of discussion these days. And similarly, the sella dura, which gets actually below the tuberculum and in front of the clival recess, is the base of the pituitary, where we open up. And the pituitary gland is actually attached laterally through these bands to the cavernous sinus. And if we have to translocate the pituitary gland, then we have to cut through these bands so that the pituitary translocation can be done. So previously, we used to do like a depression of the pituitary gland to go into the posterior fossa. But nowadays, we have found that one of the bands can be cut and the pituitary can be shifted to one side to go into the posterior fossa through this. So this is another method by which we can go through the posterior fossa through this route. So Sella Turcica, also known as the Turkish saddle, is actually sitting there, and we have already discussed about the anatomical landmark of the Sella Turcica. So just to recapitulate, it is the tuberculum sella, which is in the front, and at the hypophyseal fossa, and then the dorsum sella, and it is bounded by the posterior clinoid process. So there is a thing also known as middle clinoid process. One should be aware of this variation. Sometimes the middle clinoid process together with the anterior clinoid process can make a bony canal like this. So this makes a bony canal for the internal carotid artery as it comes out of the clinodal segment. And one should be aware of this entity before going to this area for the ACP dissections. Now, a few brief about the CT scan finding, because sphenoid air sinuses we have already discussed as basically a route through the endoscopic approaches. So whenever we are going through these particular approaches, we should be also be considering how much pneumatization has occurred into this sphenoid. So sometimes the posterior ethmoidal cells can go inside the tip of the anterior clinoid process, which is also known as ONOD cells. So whenever we are opening the anterior clinoid process, one should be cognizant of this fact, or else the patient may land up with a CSF rhinorrhea later on. Similarly, is the condition of the pneumatization of the sella, which should be appreciated. So if the pneumatization is restricted only to the tuberculum celli, then we call it a pre-sellar pneumatization, and these are very difficult bone to drill through to reach the sella. And the most appropriate is the sellar pneumatization, where the whole floor of the sella is actually pneumatized. And if the pneumatization reaches up to the dorsum celli, we call it as a post-sellar. And actually, this particular pneumatization variation actually allows a very good access to the clivus from the transsphenoidal approaches. So other than that, one should be also aware of the pneumatization which is there between the foramen rotundum and Vidian canal, because as I've already told in the endoscopic approaches, we need to know this Vidian canal and the Vidian nerve as it is coming out. So whenever there's a pneumatization has occurred, very less drilling is required and one can easily go through it. And similarly, this is another CT scan view where one can see the ICA, the Vidian canal coming out through the foramen lacerum. So the foramen lacerum, you know, the deep petrosal nerves joins GSPN to form the Vidian canal, Vidian nerve, and the Vidian nerve actually comes into the pterygopalatine fossa tubules. And then this particular CT scan actually shows the communication between the middle cranial fossa and the pterygopalatine fossa through the foramen rotundum. And here in this particular CT scan, one can see the superior orbital fissure and then the optic nerve going through the optic canal. So just a brief about how we are actually exposing this particular bone in our routine surgeries. So we all know pterygopalatine crinotomy is the workhorse of the neurosurgeons these days. And the pterygopalatine crinotomy concept is just like a cone. So wherever we are trying to base our focus, that particular cone should be actually either be put forward or backward, can be put upward or downward accordingly to reach that particular thing at the base. So whenever we want to go much more posteriorly or towards the middle cranial fossa, we want to come much more, and we want to expose it much more from the front, so frontozygomatic approaches. And similarly, when we are trying to go into the sella, to the cavernous sinus and other approaches, then we go from the middle fossa approaches. And nowadays, people are becoming much more focused in the minimal invasive surgery era. So people are talking of mini pterynal and even micro pterynal crinotomies. So this is just a variation, but then most of these approaches goes to this sphenoid wing into the anterior crinoid process. So beside this, one should also be aware that whenever we are planning any skull basis approach, this is the axial view which we should always consider. So this is for the residents who are listening to this presentation. So this is very important for us to appreciate the axial view, because this will give us an extent about how much we can approach. And then through the sphenoid, the other corridors which we have been discussing in the last many decades had been through the subappendibal approaches. But with the advent of the endoscope, we are doing a lot more of these surgeries by endoscope. So there are two lines which everyone should be aware of. One is the superior line, which actually attaches the nostril to the floor of the pituitary fossa. So this anything above it is known as transsellar corridor. So it actually gives a very good view to the pituitary gland. And below it, depending upon the pneumatization of the sella, which can give you an approach to the posterior aspect of the clivus. And then the second line is the inferior line, which attaches the nostril to the floor of the pneumatized sphenoid. So anything below this inferior line is the infrasphenoidal corridor. So in this case, you can actually go transclival without going through the sphenoid sinus. Air sinuses have been in vogue because these are actually the passages to a lot of structures, both midline as well as on the lateral aspect. So I won't go into detail about this. So to summarize here, the sphenoid bone actually forms the anterior and the middle skull bases. It has attachments to both the skull base and calvular bones. And we need to study our CT scans properly to know the vascular and the sinus anatomy, and as well as to make our plan as to how the surgical approaches has to be made. And it is anatomy is very important to identify the key strategies to access the lesion inside or hidden behind. Thank you for your patience listening. And I have some physiological videos also to show, but then in the sake of time, I will skip that and I hand over to you and I will answer any queries if in case there are. Thank you.
Amit, excellent presentation. Um, Very good. So, I mean, I just wanted to raise a few points right now. Give me a second, guys. Give me a second.
Thank you, Professor, for this nice presentation. Very excellent and very nice pictures and very nice dissections and very, very nice explanation. We all enjoy this lecture. Thank you very much. And also thank you to Dr. Mohammed Nawaz and Dr. Hussein Dorel for their presentations as well. Dr. Aib?
Yeah, so first few things. Number one, the sinuses for UGL. We have a large publication in two publications and a textbook chapter on how the sinuses helps the brain to cool. So maybe you guys should read up, and then I'm going to share my screen and show you some of the frontline work that we've been doing when it comes to endonasal approaches. So I'm just going to share my screen. Can you see my screen?
Yeah.
You can see my screen?
Yes, it is.
Yes, we can see it.
All right. So first thing is the subdiaphragmatic dissection. That's the most important thing. So when you have large pituitary tumors like this, for example, what is important is that you must always be under the diaphragm. When I see people doing pituitaries from above, one of the things that they take out saying it's a capsule is with the diaphragm. So you must understand the pituitary stalk pierces the diaphragm and goes. So when you take the diaphragm off, that means you are cutting the stalk and creating, irreversible DI. So this is what we're going to show. So see, it's a pituitary. It's a 3-minute video, everything together. So you can see how large it's pituitary. It's a solid tumor. But after we've done it, we're starting from 2 o'clock, and then from 2 o'clock to 10 o'clock, we're finding the diaphragm. And once we find the diaphragm, we dissect the tumor off that. That's most important. So keeping on removing microsurgically, you keep on removing the tumor under high zoom, and you will see that the tumor is completely removed, and this patient doesn't have any pituitary dysfunction. Generally, you would expect pituitary dysfunction with this kind of tumor resection, but then you won't have any tumor. This is another case where this is a brainstem lesion. It's a pilocytic astrocytoma. So you can see the basilar is completely displaced to the right side. So to get a window here, what you must do is the sixth nerve is here. The sixth nerve must be lateralized. So Amit was talking about some of the ligaments. So to lateralize the sixth nerve, what you need to do is you need to come in here, medial to the paraclival carotid, and after that cut the PPCL, the posterior petroclinoid ligament and the petrosphenoid ligament, and then lateralize the sixth nerve, and you have a huge window here. Only thing is you have the perforators here. So you will see that. Right now, what you're going to see is you're going to see this tumor here. You can see the basilar in front. And you can see how this is, and that's why we chose this approach. So that's the paraclival carotids. That's the Sella So we're going to remove off the PCPs here. We're going to drill and remove the PCPs here. First, you identify the Sella, and then you're removing the PCPs there. On the left side, we'll remove the PCPs and then go in. So that's a drilling of the PCP. The Sella is being displaced upwards, clivus, upper clivus, and then the PCP, which is connected to the upper clivus, is being removed. Once you do that, then you can go in there, and that's your vertebral artery. And because the basilar is displaced completely to the right side, now you're going to the left side, and that's a released sixth nerve. That's a sixth nerve which is released. PPCL and PSL released, and that's a Gulfar segment of the cavernous sinus. You stop the bleeding with the glue, and after that, this is the vertebral artery. This is the basilar artery. This is the perforator. There's a basilar perforator there, and you can remove the tumor there. Okay, so this is how after the tumor removal looks like it. So she's been on follow-up for 4 years. This is an endoscopic, this endoscopic holder, endoscope holder. So this is how we use it. My ENT colleague is using it. This is designed by us. This is another case where we are clipping pica aneurysms. We now started clipping posterior circulation aneurysms with this approach. With the headed flap, it's beautiful. So this is a pica aneurysm. So it's apparently the second case in the world. So you can see that's a pica. That's a pica there. That's a 12th nerve roots. And then you can see we put in a temporary clip first to check the aneurysm, dissect the aneurysm. So that's aneurysm being dissected out there. And once you dissect out this aneurysm, then you can put in this clip. So we've started using a lot of 3D endoscopes. So we have the Einstein Vision, which is a 3D endoscope from Esculap. So that's an excellent, that's a game changer, I must say. And then we have the endoscopic holder, the robotic holder. So we don't have much time to show all this in detail, but I'm just showing this much thing. So that's a neurocongress that we organized recently. We had the president of the WFNS come here. So thank you very much, and excellent talks, everybody. God bless, and fantastic conference, Ahmed and Ujail, then Nawaz and Ameet. Excellent talks. Thank you very much.
Thank you, everyone. And by this, I think we can conclude this session. And with this great presentations by each of Dr. Muhammad Nawaz and Dr. Yusil Turel and Dr. Ameet Thaba. Thank you, everyone. And thank you, Dr. Aib, for moderating this session. And thank you, everyone. And to the next Friday, inshallah, we'll have another session. First, we'll have a presentation about anatomy of the anterior fossa by Dr. Aib Cherian, and then anatomy of the middle fossa by Dr. Let's check. Okay. Sorry for that. So next Friday, we'll have anatomy of the orbit and its contents by Dr. Mahjibin Mimoun, and then anatomy of the anterior skull base by Dr. Aib Cherian, and last we'll have anatomy of the middle cranial fossa and the microsurgical approaches by Dr. Victor Hugo Perez. So thank you, everyone, and until next week, we can meet, inshallah. Thank you, everyone.
Thank you.